Okay, today we're going to be talking about sepsis or septicemia or septic shock. As we're going to talk about in a few minutes, all of these terms are kind of used a little interchangeably. They do mean different things, and I will define them, but they kind of all refer to the same thing. And generally, even though on the calendar and in your class it's called septicemia, most people just refer to this is sepsis. And so you hear people talk about sepsis a lot. This is what they're referring to. So let's get started. As we get started, I want y'all to think about the major concept that cellulitis and septicemia fall under. And specifically, if you look at the course, they fall under homeostasis, right? So why do these issues related to infection and immunity, why do they fall under homeostasis? Well, the reason is because when we have an infection, when we have a problem like sepsis, what we're really talking about is a breakdown in our body's ability to maintain homeostasis, either because the infection is too, too strong. It's like it's not being treated effectively by the body, or because the body's response to the infection, it trying to fight it off, is actually interfering with how the body functions, and it doesn't end up functioning well. So when we talk about today, we're mainly focusing on how sepsis is a problem that causes the immune system to basically impede or impair homeostasis. Every year there are about 1 million cases of sepsis in the US, so that's pretty significant. The mortality rates for patients who become septic are about 30%. They can be as high as 30%. So you think about that, about a third of patients that become septic will die. And for patients that become, where they go into what's called septic shock, that mortality rate is 80%. So once someone goes into septic shock, the odds of them surviving are very low. And we're going to go into what septic shock means, but again, sepsis is a huge problem, and it's really important that we as nurses take care of it. And the best way, the biggest tool that we have as nurses to fight sepsis is prevention. And the way we prevent it is through having really finely tuned assessment skills. Assessment is going to be probably the most important aspect of treating and hopefully preventing sepsis, because as you're going to see going forward, the treatment is pretty straightforward. There's not I don't want to downplay it, but the treatment for sepsis is not all that complicated. But what's important is identifying it early and beginning that treatment, because if we don't, people can die. This page has some terms. I've already used a few of these, and like I said, they're kind of used interchangeably a lot of times to describe the same thing, but they do have different and specific meanings. So I'll go into what they mean. Septicemia just means the presence of pathogens and toxins in the blood. Bacteremia just means the presence of bacteria and toxins from bacteria in the blood. So, bacteremia is the same thing as septicemia, but, not all septicemia is necessarily bacteremia, though typically it is. And then sepsis is just whole body inflammation caused by an infection. So it's an inflammatory process and response that comes about as a result of an infection. And so again, these terms they're used pretty interchangeably. For the most part, when you hear people talk about sepsis, you're going to hear them use the word sepsis, but you might hear them use septicemia or bacteremia. You might even hear a few other terms that we'll get into, but really sepsis is the one that everyone's referring to and the one you're going to hear the most. To understand what sepsis is, we first have to understand what we mean when we talk about whole body inflammation. On that previous slide, the definition was whole body inflammation caused by an infection. So what do we mean by whole body inflammation? Well, in a few slides, we'll talk more about this, but many of you in the clinical setting have probably already encountered an assessment that nurses and PCAs do called MUSE, which stands for Modified Early Warning System. And MUSE is a collection of assessments, and we use those to kind of judge how stable a patient is, and monitor for signs that could be indicative of sepsis, but also some other problems. Well, Muse helps us identify whole body inflammation, but really the core of Muse, most of those Muse values are based on what's known as SIRS, S-I-R-S. And SIRS stands for Systemic Inflammatory Response Syndrome. And the SIRS criteria are here on this picture before you. And the SIRS criteria, there are 4 vital signs or lab values that we're going to look at, right? 4 criteria. And those criteria are a temperature that's greater than 100.4 degrees Fahrenheit or less than 95 degrees Fahrenheit. One criteria is a respiratory rate greater than 20 or a PaCO2 of less than 32 millimeters of mercury. Another criteria is heart rate that's greater than 90 beats per minute. Now, again, normally we think of 60 to 100 being the normal, but SIRS typically identifies it as greater than 90. And then the last criteria is a white blood cell count greater than 12,000 or less than 4,000, right? Depending on the source you look at, these SIRS criteria might differ a little bit. And depending on the Muse scale you look at, there will be most likely some other criteria that are thrown in, and these values might differ a little bit. But these are generally the four SIRS criteria, right? And so again, the values might differ slightly. You might see one that says, the white blood cell count greater than 11,000 or less than 3,500, or the temperature is a little bit different, but more or less, this is what we're looking at. And so when we talk about why this is important, what does the SIRS even mean? Well, again, SIRS, if someone meets either of these 2 out of 4 criteria, so if they have a temperature that's 102 and a heart rate that's 120, technically we say they are in SIRS, that they meet the SIRS criteria. They're having a systemic inflammatory response. If you look below those 4 criteria, it says sepsis. And so sepsis is defined as SIRS with a microbial source. So if someone is septic, in other words, they have that whole body inflammation, that means that they've met 2 SIRS criteria, indicating that yes, they have whole body inflammation. And if it has a microbial source, that means that it's caused by an infection. So that means they're septic. Severe sepsis, and we'll go over this in some upcoming slides, but just very briefly, severe sepsis is sepsis with one organ system dysfunction. Septic shock is severe sepsis with hypotension that does not respond to fluid resuscitation. And we'll get into more of what fluid resuscitation means in a moment. And then MODS, which is multiple organ death syndrome or multiple organ dysfunction syndrome, is when there's at least one organ system, but generally more than one organ system, that's requiring interventional homeostasis. And that means that something like a good example would be the kidneys are failing, and so they need dialysis, like emergency dialysis. The organs are no longer functioning, and we need an artificial means to preserve the body continuing to exist and to function correctly and maintain homeostasis. I know that last slide had a lot of information on it, so we're going to break it down and we're going to kind of go over a lot of that information piece by piece now. But I just wanted to kind of throw it at you all at once, just to kind of give you a preview, and now we'll go into a little bit more detail. So again, SIRS is Systemic Inflammatory Response Syndrome. And again, it's a systemic inflammatory response. It's generally the result of an immune response to an infection. But it's not always. If you go back and look at that previous slide, a heart rate of 150 and a respiratory rate of 26 would mean that you meet SIRS criteria. And personally, if I go for a jog, I would already, my heart rate would probably be around that, and my respiratory rate would be elevated like that, right? So if you go for a jog, immediately you already meet SIRS criteria. That doesn't mean that you are sick. You might feel sick because you just went for a jog, and if you're as out of shape as I am, then yeah, you might feel bad, but you don't have an infection and you're not septic, right? So again, these are clinical signs and they're clinical clues. But when we talk about SIRS and we talk about sepsis, sepsis is when you have two or more of those SIRS criteria that you meet, but you also have the presence of an infection, or it's suspected that you have an infection. It's not just that you just walked up a flight of stairs. It's that you're sick, you have an infection of some kind, and that's what's causing these changes in your vital signs or your lab values. All right, so these next three slides describe the kind of pathophysiology of SIRS and what's happening in the body. They're kind of medicalese, they look like the kind of thing that you read and your eyes roll back into the back of your head because you're like, oh, I don't understand what any of this means. It's a bunch of words, but you have to read it a few times. So the reason I'm including it is not to confuse you. It's because these next three slides, if you look in any like medical source, medical encyclopedia, most textbooks, your textbook for one, but pretty much any textbook you read, you will find this information. You will find the same thing word for word somewhere when it talks about SIRS or sepsis. And so I wanted to include it just to kind of explain what it is it's saying in a little bit more, not layman's terms, but terms that maybe are a little bit more approachable. So don't feel like you need to like memorize what's on this slide or the next two slides. It's more just trying to help give you some context. So as you read this, if it's not immediately apparent, some of you might read it and be like, oh, I understand completely what that's saying. But if you don't, just to kind of explain what's happening. So in SIRS, what happens at the start is, there's a local problem. You have an infection or an injury somewhere, and the body initiates the local inflammatory response. So basically, the local cells initiate the inflammatory response, which involves local cytokine production. And this helps with wound repair, and it also helps with what it says here, the recruitment of the reticular endothelial system, which is basically the parts of the immune system that are housed locally in the connective tissue in that area, right? So in your connective tissue, there are some macrophages, there's some platelets that are available kind of as like first responders, right? So that's what's happening at the first point. There's an injury, and there's kind of a local response to that infection or injury. What happens next is, again, there's this local response, and it starts to recruit some of the, again, macrophages and platelets and other elements of the immune system to come in and fight off this insult or injury, right? Typically what happens is as this is occurring, your body starts to release antagonists. So things that are actually trying to decrease inflammation, right? And the goal here is to basically maintain homeostasis. It's kind of like your body activates the immune system, in the local area, all these platelets and macrophages and stuff kind of rush to the scene. And then once they get there, the body's almost telling them like, okay, we have enough people here. We don't need any more. So like they'll handle it. Everybody else kind of go about your business. It's almost like you could imagine, you're on the hospital. There's a code, somebody grabs a crash cart, everybody's rushing into the room, and eventually, if we kept sending people into the room, eventually the room would be full. And sometimes that does happen, unfortunately. But at some point you have to say, like, okay, we have, some doctors, we have some nurses in here, we have a respiratory therapist, we don't need anybody else. Everybody else kind of go back to making sure everybody else in the hospital is okay, right? So that's kind of what your body's doing. Your body's saying, okay, we have enough macrophages and other immune mediators that are here, and we're good to go. We can start kind of dialing back the immune response. As the body starts to do this, as it starts to try to kind of tell the immune system to chill out more or less, and basically that it has under control, if one, it's not actually under control, and the antagonists that are fighting against the pro-inflammatory mediators, if the signals basically saying that no, we need more of an immune response are greater than those saying no, you can relax because the infection is winning or it's getting worse, then the immune system is going to keep mobilizing. Or if those mediators aren't, for whatever reason, produced for some reason, then again, the immune system is going to keep mobilizing. So what happens if that occurs is that homeostasis isn't restored. It means that the immune system is still activated and it's still trying to fight off this infection. And so as a result, it starts to actually cause a breakdown in the integrity of the circulatory system primarily. So we have all these white blood cells and macrophages that are in the area, and they kind of like clog the highways that are your arteries and veins, right? If all these pro-inflammatory mediators are around, it means that there's not as much room for basically the red blood cells, right? They get in the way. Plus, on the microvascular level, as your body's activating the immune system, it's also activating platelets. And as these platelets are activated, they start trying to clot. And so they can form clots in the capillary beds, like in the very small capillaries, which is actually where the exchange of nutrients and oxygen and CO2 happens at the cellular level. And once that starts to happen, it means that the cells of the tissues that those capillary beds are supposed to be supplying with nutrients and oxygen, they can't actually get to the cells and to the tissue, right? So the major arteries and veins they've still got blood flowing, but it can't actually get through those capillary beds. And as a result, this is what can lead to that end organ dysfunction or the death of certain organs or tissues. And this is obviously very bad. This is why sepsis is such a serious problem, because it can lead to organ death. And that's really kind of the end stage of sepsis is, organ death and then eventually person death. I know I already talked about this, but I'm putting it up again just because I hit you with a lot that first slide where we talked about SIRS. But just as a reminder, so SIRS criteria are these 4 criteria. It's a temperature that's greater than 38 degrees Celsius or less than 36 degrees Celsius. It's a heart rate greater than 90. It's a respiratory rate greater than 20 or a PaCO2 of less than 32 millimeters of mercury, and a white blood cell count of greater than 12,000 or a white blood cell count that's less than 4,000. Just for the record, you might also see white blood cell counts expressed in not in the thousands, but in the single digits. So if you were to see a white blood cell count of 8.3, you could also read that as 8,300. So just so you know, depending on where you work, you might see them expressed differently like that. So if the patient meets 2 or more of those 4 criteria, then we say that they are in systemic inflammatory response syndrome, or SIRS. If they have the presence of an infection, that means that they're septic. One thing to remember is if you look at some of these criteria, having a respiratory rate that would be, say, 28 and having a PaCO2 that would be something like, we'll say also 28, that would only still meet 1 SIRS criteria, right? So it's 2 or more. That counts as 1 SIRS criteria because it's a respiratory rate of greater than 20 or a PaCO2 of less than 32. So again, 2 or more of these SIRS criteria means that the individual meets the SIRS criteria, and if they have the presence of an infection, that means that they also are considered septic. Now, I just spent the last few slides talking about SIRS, and it's important to know those SIRS criteria, but the reason it's important to know them is not because you're going to see SIRS in the hospital. You're not going to see the word systemic inflammatory response syndrome. You're not going to see the acronym SIRS. You will obviously be monitoring for those signs. But what the hospitals use, they don't just use like the SIRS criteria checklist. They use what's called MUSE and PEWS, which MUSE stands for Modified Early Warning System, and PEWS is the Pediatric Early Warning Signs, so for pediatric patients. And these are very similar to the SIRS criteria. They're based in large part off of the SIRS criteria. However, they have a few other assessment findings included in them. Plus, they tend to break down some of those values a little bit more. So in other words, instead of just saying a heart rate greater than 90, they score all of the assessments that they're asking you to look at. So in other words, depending on the Muse scale that's being used, a heart rate of 100 to 120 might give you 1 point, but a heart rate from 120 to 150 might give you 2 points. So it's a little more nuanced and it gives us a little bit more information, but they still contain and they're still based off of those SIRS criteria. And there's a few examples in the next few slides that I'll show you of what a Muse scale would look like. But many of you have been in the hospital and seen these already. So just if you recall what you've taken for your Muse, that's what the Muse score is. And the reason that we use those primarily is to evaluate for sepsis. They're a little bit more expanded. They can help us detect other problems beyond just sepsis, but probably their primary function, probably the thing that they're used most for, is to evaluate for sepsis. Again, they can be used to help us just kind of monitor the general health of the patient and generally whether they need critical care, like if they need to be sent to an ICU or something. But the main purpose is to help us identify and respond to patients who are becoming septic or who might become septic. I mentioned that Muse oftentimes includes assessment findings that are not in the SIRS criteria. So they have some additions to the SIRS criteria in Muse. Typically, those extra assessments that we're looking at are urine output. Generally, we're monitoring for decreases in urine output. Another big one is blood pressure. Generally, if we're worried about sepsis, we're worried about blood pressure being too low. However, with Muse scores, again, they're not just for sepsis monitoring, and so they also include a scoring oftentimes for blood pressures that are too high. But for sepsis, and again, we'll discuss this in a moment, but for sepsis, we're really worried about their blood pressure being too low. It's not very common that someone would be septic and we would see their blood pressure very high. Typically, in almost every instance, it's going to be too low. And then the other assessment that is very common in Muse scoring is mental status. So the level of consciousness of the person or their level of orientation. You may also see that the Muse scoring might use their score on the Glasgow Coma Scale, which I believe I also mentioned before in the cerebrovascular accident material, which you'll also go into more detail when you learn about traumatic brain injuries later on in the program. But again, the Glasgow Coma Scale is just another way that we use to score and monitor a person's level of orientation or confusion. It's really more measuring their response to stimuli. So again, they oftentimes will just ask for how oriented is the person. Do they know their name? Alert and oriented times 4. But they might include a little bit more in-depth assessment, like something like the Glasgow Coma Scale. And so this is what a Muse scoring system can look like. This is one example that I found. And again, there's multiple ones. They're not all the same across all facilities, but generally they have a lot of similarities. And so if you look at this, if we look in the very middle of the column, we have 0. If you look right between early and warning, there's a column at the top that just says 0. And then if you look over to the left, we have respiratory rate, heart rate, systolic blood pressure, conscious level, temperature, and then hourly urine for 2 hours. And so if we look over in that 0 column, if those values fall in those ranges, we don't give a score at all. If you look to the left or the right, as those values increase or decrease by a certain amount, we do give them a point or 2 points or even 3 points. So in other words, a heart rate of 140 would mean that we would score 3 points for their heart rate. A systolic blood pressure of 90 would be 1 point, right? You can see that. So then if we look at the very bottom, it gives us then some directions based on that score that we calculate from looking at all of those assessments. If you look, it says in this particular example, again, it depends on the scoring system, but in this scoring system, if the score is between 1 and 2, we should start performing our Muse scoring every 2 hours, and we should inform the charge nurse. So let the charge nurse know that, I have a patient who just scored this on Muse. Typically that means that, we're telling them we need to put them on sepsis alert and that we need to start checking the Muse every 2 hours. So that basically means we're needing to start taking their blood pressure every 2 hours. If the score of your patient is 3, we need to start performing 1 to 2 hourly observations. So potentially moving the frequency of the Muse scoring to every hour and still inform the charge nurse. If the score of the patient is 4 or more, then we need to be performing observations every 30 minutes, and we need to contact the physician if we have not already, and contact the urgent care team. So that would be like a pit crew or a rapid response team or someone like that, right? And then it says between 3 and 4, if the Muse is deteriorating, the doctor must attend, or in this case, probably more likely, they must be notified, right? So we can see that as their Muse score is increased, basically what we're doing is we're saying we need to start monitoring their Muse more, and probably we need to start moving them to a higher acuity level. If you're taking vital signs every 30 minutes, that is too often for a patient to be on a medical surgical floor where the nurses have 4 to 5 patients, if they are getting that done regularly. If it's a period of time, like for example, for blood transfusions, where we do have to take vital signs a little bit more frequently for a shorter period of time, that's acceptable. However, if we are needing to start taking these vital signs, and even more than just vital signs, some of these are additional assessments, if we have to do that at least every 30 minutes, well, they need to be on either an intermediate care unit or an intensive care unit, because the nurses on a med-surg unit do not see their patients every 30 minutes. That would be really nice if we can, and sometimes we have that ability, but usually we can't. So really, this is, as you can see, most of these interventions are basically saying start monitoring them more frequently. And this speaks again to the fact that a big part of treating sepsis is being on top of our assessments and preventing it from happening and intervening early if we notice that it is happening. This is another example of a Muse, not scoring system really, but more a interpretation of Muse scores, right? Just to kind of give you another example of what you might see. And so in this one, at a very low range, then it says the frequency of monitoring just every 12 hours. So in other words, about once a shift, we just need to check their Muse, right? And that's pretty standard for most patients that are admitted to the hospital. If it's a little bit higher, then we'd want to start taking it every 4 hours. And you've probably taken care of patients in the hospital who have Q shift vital signs, and then others who have Q4 vital signs. Generally, we're assessing those patients who have Q4 vital signs a little bit more frequently than those who are Q shift, right? And then as you see, the clinical response also escalates over time, right? So, at the midpoint, we're saying we need to notify the charge nurse. We might consider calling a rapid response, depending on how bad the patient is. Maybe if we're not able to get a hold of the primary care physician, then that would be appropriate. And then at the highest level, we need to start taking their Muse at least every 2 hours. And then we're, again, looking at calling a rapid response team. We're looking at transferring the patient to an ICU or a step-down unit. We're basically trying to get them into a more acute care setting, because they're going to need a lot more aggressive treatment by both the nurses and the physicians, and they're also going to need more frequent monitoring. 15 slides into the lecture on sepsis, and we can finally talk about what sepsis is. Thanks for sticking around. So, as I've mentioned before, sepsis is the result of an infection. It is an infection that has happened. And the body is unable to fight off the infection, or in some cases, it could be a situation where the immune response to that infection is so great or too heightened that it causes a breakdown in the body's homeostasis. It's oftentimes a combination of these two things, right? That's what sepsis is. And so, again, sepsis is the classic definition is SIRS, so it meets SIRS criteria, and there's the presence of an infection. However, more and more, we don't use SIRS, we use Muse scores. And a high Muse score with the presence of an infection, we say they're septic. We also say, oftentimes, that a high Muse score or the presence of the SIRS criteria with even the chance of an infection, with a likely infection, that is also treated as though it's sepsis. Because again, if you remember back to that very first slide, maybe not first, but very early on, that the mortality rate for a patient who enters into septic shock is extremely high. And so we need to be prepared to intervene very quickly and very early on to prevent a patient from going into shock, which we will talk about in a little bit. Continuing on, sepsis basically is just the lack of blood flow to the tissue caused by the systemic inflammatory response. So what's happening is that at the microvascular level, the capillary beds are getting clogged with these microthrombi, and they're getting obstructed. And in addition to that, there's damage being done to the lining, the endothelium of the capillary wall, so the arterial and venous walls. And this is causing damage, right? As all this is occurring, systemically, the body is vasodilating, right? Because again, what it's trying to do is it's trying to increase the perfusion to all the tissue. But what ultimately ends up happening is that as the vasodilation occurs, the blood pressure drops so low that the body can't perfuse. So again, generally with sepsis, one of the key things we're worried about, even though it's not one of those SIRS criteria, we want to measure the blood pressure because a very low blood pressure is an important sign in sepsis, and it's indicative that the patient is going into septic shock. And as the blood pressure gets low enough, it means that the patient's organs are no longer perfusing. As this process continues with, on the macrovascular level, vasodilation occurring in all the major arteries and veins, and at the microvascular level, the blockage of the capillary beds and the destruction of the vascular endothelium, what happens is, again, the tissues to the major organs can't perfuse. They're not able to function because blood isn't able to get to them and exchange nutrients and oxygen. And so when this starts to happen, we say that the patient has severe sepsis. And this is when one organ or organ system starts to become damaged or starts to not function well. And as this continues, it can eventually lead into what's called septic shock, which we'll talk about in a few more slides. I wanted to pause for a moment and discuss what's known as disseminated intravascular coagulation, or DIC. Now, DIC is a condition that can occur. It occurs very frequently in septic patients. It can also occur in some other patients that aren't septic. It's common in some other conditions, but sepsis is one of the biggest causes of DIC. And DIC is, as I was describing before, this widespread activation of all the clotting mechanisms in the microvascular of the body, right? So it's just your body doesn't need to be forming these clots, but because of this exaggerated immune response, the body is forming these thrombi when it doesn't really need to form them. And so again, what this does is it leads to blockages and an inability for the body to perfuse tissue. And so this leads to a drop in tissue perfusion, and this helps contribute to the organ damage or organ failure that can occur in sepsis and septic shock. So hopefully you read this slide and think about it a little bit before listening to me kind of describe it. But as it says, even though DIC is characterized by excessive clotting, the patient's actually at high risk for bleeding. And it seems counterintuitive at first because you think, well, the patient is having all these clots, they shouldn't be bleeding because the clots are all being mobilized. But that's actually the problem. So as these platelets are being used up and forming these microthrombi in places they don't really need to be, it means that the body isn't actually able to address breakdown in the vascular endothelium where it actually needs to. So in a place where there actually is a cut, where there does need to be a clot, the platelets have already been used up and they're not able to clot off anymore. In addition to this, the formation of these microthrombi within the vasculature actually breaks down and hurts the integrity of the vascular endothelium, so the lining of the arteries and veins. And as a result, it actually makes it more likely that the arteries and veins do bleed. And so, again, assessing for signs of bleeding and internal bleeding as sepsis develops can be a really important assessment because, again, it's something that can happen and can make the patient deteriorate even faster. And this is just a diagram kind of showing how DIC works or how it can work. In the first example A, that's a normal anatomy. Example B, you can start to see the formation of these microvascular clotting and microthrombi. And then as it progresses, you see more and more blood is blocked in figure C. And then in figure D, all of the platelets have been used up, and so there's none left to actually address this ruptured vessel or artery. And in addition, it's probably been made weaker by the formation of these clots on the lining of the artery and wall. Now, if you read some of the descriptions, this is talking about during pregnancy. And again, DIC is something that can occur in other instances besides sepsis. So this one's specifically referring to DIC in pregnancy, but it's the same process. The DIC still happens in the same way. It's not unique to just sepsis, like I mentioned before. So even though this slide is talking about DIC in a pregnant individual and how it can develop, it's still the same. It's still the same process that's occurring. Now the question becomes, how do we treat this DIC? Because obviously it's a major factor contributing to the deterioration of a patient that has sepsis, because it happens in a lot of patients with sepsis. So we need to understand how we treat it. The first thing is we need to continue monitoring their vital signs and their clotting factors. That's a given. We'd be doing that anyway, hopefully. We need to assess for signs of bleeding and hemorrhaging, even both externally and internally. One of the things we're going to want to do is fix any hypovolemia, because hypovolemia can contribute to DIC. And one of the things that we're going to talk about is that one of the main treatments for sepsis is delivering fluid, giving a lot of fluid. So generally this is going to be something that we're doing anyway. And just so that you don't get confused later, the reason we give fluid in sepsis is not because the patient is necessarily fluid deficient or because they're dehydrated. The reason is because we're trying to stabilize their blood pressure because they're vasodilating so much. But hypovolemia can obviously contribute to that. The other thing that we might do is we might give platelet transfusions. Now, platelet transfusions and giving anticoagulants are both very dependent on the circumstances. And it really is going to be on a case-by-case basis. So the reason for that is because both giving platelets and giving anticoagulants might be appropriate in some cases, but they might be contraindicated in others, even though you could have two patients with DIC. So giving someone a platelet transfusion while they're experiencing DIC, while they're in the middle of maybe an exacerbation or when the DIC is going on, what can actually happen is it can make the condition worse because basically the body's using up all these platelets, and once you start giving platelets, the body might say, oh, gee, thanks. Now I can make even more clots throughout the body with these. So usually platelets are given after it seems like the DIC is starting to resolve, or possibly prior to, in order to prevent internal bleeding or something like that. Similarly, with anticoagulants, right? When we see that DIC is starting to develop and it's happening slowly, we will put them on heparin or other anticoagulants to kind of prophylactically treat the DIC and make sure it doesn't happen. Once someone is experiencing DIC, once it's developed, we don't want to give them anticoagulants because obviously it's going to put them at even greater risk for bleeding because they no longer have any of their clotting factors. So again, whether you give platelets, whether you give anticoagulants, whether you do either or anything, it's really, really case dependent. So there's not a hard and fast answer of what we always do for a patient with DIC. Assuming that the worst happens, so assuming that our patient becomes septic and we don't do anything about it, or the things that we do aren't good enough to help stop it, what eventually happens is that the patient will go into septic shock. So the question then is, what is shock? Because there's a lot of different types of shock, and septic shock is just one of them. And you're going to learn more about some of the other types of shock later in the program. For today, we're just going to talk about septic shock because you can't talk about sepsis without talking about septic shock. But generally speaking, when we say shock, when we talk about shock, what we're talking about is insufficient blood flow, lack of perfusion. And this lack of perfusion basically means that the major organs and organ systems aren't being perfused, and so they start to experience cell and tissue death, right? So the exact nature of why there's insufficient perfusion depends a lot on the type of shock. So for example, in hypovolemic shock, which some of y'all might have probably heard of, and it's kind of self-explanatory, your blood volume is too low, and so you're not able to perfuse appropriately. In septic shock, it's the result of this whole body inflammation. And really the main driver is the body's systemic vasodilation. So again, in sepsis, the patient is going to experience pronounced vasodilation, and that's going to potentially, if we don't, help treat the infection, help stabilize the patient, it can lead to their blood pressure and MAP dropping so low that they're not able to perfuse. And so that's generally what septic shock is. Now that we've talked about what shock is, the way we describe septic shock is it's sepsis with hypotension, right? So a low blood pressure. Now, what's key is people going into sepsis or people with sepsis oftentimes are going to have low blood pressure, and it could be one of the warning signs that someone is going into sepsis or septic shock. So one of the things that we really, I guess a good shorthand way to remember if someone is septic or not is it's sepsis with hypotension that isn't resolved by fluid replacement therapy. And when I say fluid replacement therapy, I don't mean normal saline at 30 mils an hour, keep vein open. What I mean is intense and aggressive fluid replacement. So usually given as a fluid bolus. So a bolus is, can vary how much we give and how fast, but generally it's a liter of fluid that's given to gravity. That means we don't run it through a pump. We spike the bag, we run it through the line, and then we hook it up to the patient and we let it go as fast as the the IV will allow it to go in. Sometimes it will still be put through a pump just to make sure that it's delivered at the rate that the nurse wants, but the rate isn't going to be prescribed by the physician. And the rate that the nurse will put in is something like 999 or some really, really high number for the mils per hour. So again, when we talk about fluid replacement, we're talking about giving the patient a lot of fluid as quickly as possible. And after we do that, if the blood pressure hasn't come up to an acceptable level, then we'd say that, yeah, the patient is going into shock. Their blood pressure is unresponsive to even giving them this fluid. And I mean, think about it. It's pretty significant because if you take a liter of fluid and put it in someone, we should see a spike in their blood pressure, even if it's just temporarily, right? In addition to this, with septic shock, we also see organ system damage. And again, this can lead to what's called multiple organ dysfunction syndrome, which is when more than one organ or organ system is starting to shut down and not work or even die off. And again, once someone gets into septic shock, their mortality rate is very high. So again, our real goal is to prevent this from happening, because once it happens, it's going to be very difficult to treat them. And even worse, after they've recovered from it, it's probably likely that they're going to have some long-term knock-on effects from this. They could have maybe damage to their kidney that's going to be with them for the rest of their life. So we really want to prevent this. We've already talked about this, but just as a reminder, so again, the organ systems start to become damaged because they lose tissue perfusion because of the systemic vasodilation and the microvascular microthrombi that are occurring in the capillary beds. So where that gas and nutrient exchange happens at the capillary level, it's not able to occur. And then on the macrovascular level, there's really, really pronounced vasodilation, which causes hypotension. And all this leads into a huge drop in tissue perfusion to the major organs and tissues. Take a moment to read over this question, think about it for yourself. Hopefully you've already done that, so I'll go right into explaining the answer and everything. If you haven't, go ahead and pause this and do that. But yeah, so the correct answer is going to be A, an increase in lactic acid in the blood. And so lactic acid is also one of the lab values that we monitor for patients who are in sepsis, because what happens is as the patient is septic and as they become potentially go into shock, again, the lack of perfusion to the major organs is going to lead to cell and to tissue death. And so as the cells start to die, it leads to a buildup of lactic acid in the serum. And so that means that it can cause, it's partially what can cause acidosis in a patient with sepsis. So acidosis is sometimes a common side effect or syndrome that can develop in patients with sepsis. So let's go through the other options just real quick and why they're wrong. Retention of CO2 in the lungs. This wouldn't be the case. Generally with sepsis, patients are hyperventilating. And if you recall, one of the surge criteria is a drop in the PaCO2. So usually, in almost all cases, it's not going to be a case where there's a retention of CO2 in the lungs. It's going to be the opposite. Similarly, C, an increase in sodium bicarbonate. This can potentially happen in a patient with sepsis or in septic shock because, again, their kidneys are probably going to be the first organ system to start to experience damage and suffer the side effects of sepsis because they're the most vascular organs, and so they are really sensitive to changes in perfusion status. But an increase in sodium bicarbonate would actually make the patient more alkalotic, right? So that wouldn't cause acidosis. It can happen that their kidneys start to shut down and they do retain sodium bicarbonate. But if that were to happen, we'd see their pH kind of be stabilized or it'd be alkalotic. And then the buildup of serum electrolytes in the blood, that would happen because, again, as the cells in the tissue start to die off, in addition to the lactic acid, they're also going to be releasing all those other intracellular components, which are those intracellular serum electrolytes. And so we need to be paying attention to things like potassium levels, sodium levels. They can become very elevated if this is happening. But again, that's not going to affect a patient's pH status. As a patient goes into shock, they go through stages of shock. So briefly, we're going to go through the three stages of shock. Again, hopefully we don't let somebody get to this point. But the first stage is compensatory shock. And so what happens here is that the patient's entering into shock, right? However, the body is trying to maintain homeostasis as all this is happening. And again, a lot of this is caused by this systemic inflammatory response, but the body usually is pretty good at maintaining homeostasis. And so as this starts to develop, the body's trying to maintain homeostasis. And so it starts to increase the heart rate, it starts to increase cardiac contractility. It tries to send out signals to start vasoconstricting, right? And so during this period of time, the signs and symptoms might not be as pronounced as they could be because the body's trying to maintain homeostasis. It's compensating. That's why it's compensatory shock. So the signs can be very subtle and they can not be immediately apparent. And this is why we talk about the fact that we need to be so vigilant about monitoring and assessing our patient's vital signs and some of these other key lab values and other assessments. Because what can happen very quickly is as these compensatory mechanisms start to fail, they very quickly proceed into the later stages of shock. And so it can happen very slowly. It might progress over a period of time, but it can also happen very rapidly. And it can almost catch you completely by surprise. And you'll think, the person looked fine a few moments ago, and now all of a sudden they're crashing. And it's because their compensatory mechanisms are functioning and they're maintaining that homeostasis, but they can only do so for so long. Now, progressive shock is what happens next. If the homeostasis isn't maintained and if the problem isn't addressed and if they aren't supported, we start to see that the MAP, the mean arterial pressure, which may have been stabilized, it may have been lower or it may have been slowly drifting down, but the body was trying to maintain it, it will continue to drop. And just in case any of y'all forgotten, we want to see the mean arterial pressure greater than 65. Anything less than 65 means that major organs and organ systems aren't perfusing, right? So what starts to happen in this progressive stage is that the cells start to lose perfusion, and so they start to fail, right? So you can read through what's happening on this slide, but basically some of those compensatory mechanisms are starting to fail and they're not able to maintain homeostasis. And as a result, the cells start to fail and malfunction and they start to eventually die. And this leads to swelling in the cells, and it can lead to edema, swelling throughout the body. It can lead to acidosis, and can also lead to, again, a sustained drop in the MAP, as well as potentially changes in the serum electrolyte levels. So hyperkalemia, hypernatremia, and some others. So another thing that sometimes can happen is you want to observe for changes to the cardiac rhythm, because that can, obviously changes in things like potassium, calcium, magnesium. Those can all change the cardiac rhythm. The final stage of shock, so again, if we've been unable to do anything to prevent this from happening, is basically it's the end of the line. It's called refractory shock, and this means that the tissue damage and the lack of oxygen have become so bad that the organs are starting to completely shut down and maybe even die off. And so at this point, even if we're able to stabilize the patient in some way, even if we're able to raise the MAP back to a level where the tissue is able to perfuse again, the tissue's already dead. And it's become so widespread that probably there's organ death that has occurred. And so This obviously means that even if the patient survives, they're going to have some very serious life-altering uh, syndromes or problems that they're going to have to deal with. Potentially a chronic kidney injury that they're going to live with for the rest of their life. And so it is common that sometimes after shock, patients, have problems with their kidneys or their lungs. They might go into acute respiratory distress, and this can cause long-term damage to the lungs. So all of these things mean that if somebody gets into refractory shock, if we're not able to prevent them from reaching this end point, that they're again probably going to die. But if they don't, it means they're going to have some very serious life-altering effects, most likely. As I keep mentioning, assessment is a huge part of all this because we don't want it to get to this point. So we want to be hypervigilant for all of the assessment findings that would indicate that a patient with an infection or a supposed infection would be going into sepsis or septic shock. So early on, the signs we want to be monitoring for are hypotension, quick, thready pulses, quick, deep respirations, typically warmed, flushed skin. Generally, the patient will be alert and oriented. Not always, but generally they should be alert and oriented. Their urine output will probably be normal because, again, their kidneys are still perfusing appropriately in the early stages, and an elevated temperature. So again, checking temperature in infection. I know everyone since you were a little kid, you've gotten your temperature taken whenever you've been sick, but it actually is a very important measurement. And the reason why is because if the temperature becomes too high, it can be a really strong indicator that someone is becoming septic. Or conversely, if it's becoming too low, it can mean that the patient is septic and their body's starting to fail. The later signs, so as the sepsis or has progressed, that you'll see, and again, hopefully you would catch this before, but again, hypotension is still going to be present, tachycardia, and possibly even associated arrhythmias because of the buildup of intracellular electrolytes within the serum level. The rapid breathing is going to continue, but typically it's going to become less deep and become a lot more shallow, so less effective. Instead of being warm, they'll probably be cool, probably have some edema as the cells begin to swell up with fluid because of the breakdown in the sodium and potassium pumps. They will potentially lose their orientation, so they could become comatose even, but generally you'll see changes to their orientation prior to that. They'll become oliguric or even potentially anuric, so their urine output will decrease or maybe even cease. And then, as I mentioned before, you might actually see their temperature decrease in these later stages because the body is failing. The immune system is just unable to actually keep functioning because of the body damage that's occurring. Now that we've spent all that time talking about how we assess for sepsis and how we need to be vigilant and how we need to intervene early, now let's actually get into what that intervention looks like. So the initial treatment is going to be what's called early goal-directed therapy. And when we say early goal-directed therapy, that goal that we're talking about is sustaining or improving the MAP, the mean arterial pressure. And the way we do that is pretty much giving fluid. We're going to give what's called a fluid challenge, which is that fluid resuscitation I mentioned before, so given in the form of a fluid bolus. And the amount we're going to give is going to be determined by the patient's weight, typically. So the standard is 30 milliliters per kilogram. So if the patient is 70 kilograms, 70 times 30 is 2,100 milliliters. So 2,100 milliliters. So basically 2 bags of normal saline as fast as possible. And like I said, that typically is normal saline. It's typically a fluid that is an isotonic crystalloid solution. So normal saline is the most common. Just it's good old normal saline. Nothing beats that. But you might also see other isotonic solutions like lactated ringers or D5 half NS. So again, normal saline though is the most common. If that fluid resuscitation does not work, if we give the fluid and their MAP does not improve, then the next step is we have to start looking at vasopressors. Okay, so we've given a bunch of fluid, their MAP hasn't increased. At this point, we have to start looking at vasopressors like vasopressin, dopamine, epinephrine or norepinephrine. Those are the most common. And one thing I want you to remember when we talk about vasopressors is that when we talk about giving vasopressors, I want you to think about where would you get these? You don't get epinephrine or dopamine from the Omnicil. You'd get them from the crash cart if you're on a medical surgical unit. And so I only point that out to say that if we're giving someone this fluid and it's not resuscitating them, and we need to start thinking about giving vasopressors, that should key you in the fact that these are located in the crash cart. These are high alert, very, very high risk medications. So we need to start thinking about calling a rapid response, and we need to definitely be in touch with the physician, right? And so moving on, the goal part of that early goal-directed therapy, again, is to raise the MAP. We want to keep the heart rate stable, and we want to keep the urine output greater than 0.5 or half a milliliter per kilogram per hour, right? And this is because as long as we can maintain this, we know that the patient is perfusing appropriately, right? So we want to keep the MAP high. We're maybe even okay with the heart rate being a little elevated because, again, that's a compensatory mechanism. It means that the body is still trying to maintain perfusion. And so, we don't want the heart rate to drop. We actually want the heart rate to be a little elevated. It probably already is elevated, and we don't want to see it drop. But then we also want to see the urine output of at least a half a milliliter per kilogram per hour. I put this slide in and this little blurb just to say that it is, in addition to those isotonic fluids for the treatment of septic shock, you will sometimes see albumin ordered. And the reason that you might see albumin ordered alongside those isotonic fluids is because that, first of all, the albumin acts as an anti-inflammatory and antioxidant. So it can help stop some of this, help control some of this inflammatory response, in addition to being a volume expander. So it also will help hopefully control and help improve the MAP. And for many, many years, albumin was the go-to therapy for treating septic shock. However, in more recent years, what's been noticed is that the benefit of giving albumin doesn't really outweigh the benefit of just using something like normal saline, and that it also has some more potential for complications. And so there's been a shift where normal saline, like I said before, is pretty much the gold standard. That's what everyone uses. And that's easy for all of us because we're all familiar with normal saline, right? But you might still see albumin ordered, and it's not an incorrect or inappropriate treatment. But generally, something like normal saline or lactated ringers will work just as well and has less chance of complications. But there are still some instances where you might see albumin or even other blood products ordered. So just keep that in mind. So if we give our early goal-directed therapy, so we give a bunch of fluid and maybe even we've had to bust out the crash cart and call a rapid response team. If this is unsuccessful and our MAP is continuing to drop and the patient's not improving, then we're going to need to admit them to an ICU. And that second point, antibiotics to treat infection, obviously if the patient has an infection, hopefully we would have already been giving them antibiotics, right? But we're going to have to start being a lot more aggressive. And what I mean by that is there's a delicate balance in giving a patient antibiotics, because antibiotics, they kind of, just like any other medication, they have to be filtered by the kidney or the liver. and they can cause other side effects and problems with the body, right? And so in the case where the early goal-directed therapy isn't successful, isn't working, then we have to start being a lot more aggressive with the antibiotics that we give, and we have to start increasing the dose, maybe even to levels that aren't common, and that could even be potentially cause complications or damage to the patient's body. But at this point in time, it's kind of a pick your poison. It's either we don't be more aggressive with our antibiotic therapy, and the patient will probably die from septic shock, and if they don't, definitely have some organ damage, or we increase the antibiotics to treat the infection more aggressively, and possibly they have some damage to their kidney or liver, but will prevent them from going into septic shock. Um, so again, just something to remember, we have to be a lot more aggressive with the antibiotics, because again, the sepsis, the cause is the presence of this infection. So we have to treat that underlying cause. It's also possible that the patient will need mechanical ventilation. We have to start worrying about them losing their airway and losing their ability to breathe. So they may need to put on a ventilator because they could develop acute respiratory distress syndrome. And then the other thing is we start looking at transfusions of red blood cells or platelets. Again, those can depend, like specifically with platelets I mentioned already, with DIC, we may or may not give platelets, but it starts to look a lot more likely that we'll have to give some blood products to help try to promote the perfusion and help maintain the MAP in the patient. Additionally, the patient may require external cooling or heating as the body is unable to maintain homeostasis and their temperature begins to increase too high or too low. They may need to, again, have cooling or heating applied to help adjust their temperature and help control it better. Oftentimes, patients in shock lack sufficient protein because of the tissue damage that's occurring. And so they may need nutritional support. Usually that's given in the form of total parenteral nutrition or a tube feed of some kind. So it could be the case that they will need TPN or a tube feeding. They might be put on a drip of a pressor like vasopressor or something else, or an epinephrine. So they could be put on an IV drip of a pressor, and that has to be very closely monitored. Again, you wouldn't do that on the med-surg floor. That would have to be in an ICU. And then we also need to start paying attention to the lactate levels. As I mentioned before, lactate levels can increase as cell death starts to occur. So we really need to monitor the lactate levels. And the normal of lactate is 0.5 to 2 millimoles per liter, right? So we need to be paying attention to their lactate levels because that's going to help key us in to what kind of complications or how bad the sepsis is going. In addition, the patient may also need some other support. So they may need temporary dialysis, which can be done. There's actually venous dialysis that can be done without the presence of a dialysis shunt or catheter. Again, it's done temporarily. It can be done via central lines, and the patient will need temporary dialysis to help keep the kidneys, well, not functioning, they've died, but to help take over the role of the kidneys if they're no longer able to function or if they're insufficient. So all of these are things that, again, in the ICU might need to be done. And again, if the patient is on this central venous dialysis, then they will not, it's not something that you as a new nurse would be doing. It's something that hospitals require their nurses to be trained on and to be certified on, right? And so that's something that could happen. Now what I want you to do is review this information about a hypothetical patient and think, does this person meet the SIRS criteria? Would you say that they are septic? And what kind of nursing diagnoses would be appropriate for the patient? And what kind of interventions are you going to to imagine you'd be preparing for or you'd be implementing right away. So imagine you're a nurse in an ER and this patient walks in, what are you thinking? What are some of the things that you as a nurse know you're going to need to start doing right away? This is just a quick multiple choice question, hopefully to just kind of remind you a little bit about one of the drugs that is used sometimes to help patients with sepsis, vasopressin. So take a moment to think of the answer, and then I'll go over it. Okay, so the answer is B, chest pain. Chest pain is one of the side effects that can occur when someone gets vasopressin. It can also cause changes in their cardiac rhythm, so it's something we have to be really careful for. An increase in blood pressure might happen, but that's good. That's what we want to have happen. It shouldn't affect the PR interval, and the atrial rate of 100 beats a minute, that shouldn't happen either. So again, the answer would be chest pain. That's what we'd want to be monitoring for, and just want to make sure that we don't have our patient tell us that they're having any chest pain, and if they're on a monitor, we want to be, which they probably will be, at least a tele strip, we'd want to check and make sure that their rhythm looks like it's okay. Another quick multiple choice question. Take a moment to answer it, and then I'll go over the answer. So the answer is C, obtaining a wound culture after the initiation of antibiotics. We wouldn't do that because it would alter the culture. So we would get the culture first, then start the patient on broad spectrum antibiotics. So blood transfusion for a patient with a hematocrit level of less than 30, that would be appropriate. Administration of antibiotics within the first hour of recognition of sepsis, that's a priority. Again, we just need to get the wound culture first. And then obtaining a pan culture, so basically one blood culture percutaneously, another one in the client's vascular access device, probably another one in their urine sample if we can get it, and then if they have a wound, getting one from their wound, and then also one from their sputum. So all that would be appropriate. But the one that wouldn't be appropriate is getting the culture after you'd started antibiotic therapy. This page is just another graphic, kind of similar to the one that was in the first couple of slides that went over what SIRS criteria were. And it's just to help you visualize it again. So again, it has the SIRS criteria here, and then sepsis, which is 2 SIRS plus a confirmed or a suspected infection, and then the qualifications for severe sepsis, and then septic shock. One thing I want to point out here on this slide is if you look on that first bar where it has the SIRS criteria, it says white blood cell count of greater than 12,000, white blood cell count less than 4,000. It also has greater than 10% bands. And band cells are immature white blood cells. So when you get a complete blood count with differential, so if you've ever seen the word CBC with diff, in the chart, it's talking about a complete blood count that is differentiating between all the different white blood cells. And so one of the ones that differentiates is the band cells, and those are immature white blood cells. So if those are too high, some Pews systems or Muse systems will also use high band cells, and that should also be something that keys you in to how quickly someone's deteriorating. Because if those band cells are really high, basically what that means is that your body is mobilizing immature white blood cells to fight the infection. So it can't even wait for them to develop into full, differentiated white blood cells. It means that it's basically mobilizing white blood cells that are almost useless, but they got to get whatever use they can out of them because the infection is so bad and the infection's winning. So that's another sign to just watch out for. This slide has a link to a pretty good and pretty short YouTube video that kind of summarizes everything that I've talked about today. I would encourage you to watch it as kind of a refresher. I think it's a good way to kind of catch up on this, maybe like when you're studying for the test or something. It's just a really good summary of everything. And then below that are 3 links to basically calculators. So they're calculators that you can use to kind of fill in assessment criteria, and then at the very bottom of the page, they will give you what the clinical suggestions would be. So, if you fill in the one for Muse, if you were to make up, some hypothetical like Muse score for a patient, as you fill it in, it'll kind of direct you to the next steps, as in, okay, based on what you've given, this would be the likely prognosis, and this is the next steps. So you can just click those and play around with them. They're another way to hopefully help you maybe visualize how we assess for this, and kind of the way we stage or grade people, and how we basically prioritize or triage them, how we're going to figure out when someone is deteriorating, and when we need to intervene, when we need to start being a lot more aggressive in our treatment. On this slide is another kind of mini case study. So what I want you to do is read over this information for this hypothetical patient, and then basically create a nursing care plan. Think about what kinds of nursing diagnoses would be appropriate for this patient, and then what kind of goals you'd want to set for those diagnoses, and then what interventions would you want to implement or expect to implement to meet those goals. And if you have any questions about that as you're doing this, or anything else in the course today, feel free to email me, and then we also have a scheduled Zoom time that we'll be going over any questions you might have on this or other content. So thanks, and good luck studying, and hope you have a good rest of the semester.